in the proximal ascending aorta. Whenever you see a patient with aortic dissection, you catch from the ascending aorta, please move your probe to another site. So you can pick up the arch of the aorta from the suprasternal, and even you can go to the abdomen. Sometimes the dissection could be extensive, and you can catch the intimal flap by putting the probe over the abdomen and looking for aortic extension of the dissection into the abdominal aorta. Still you have the probe. Why not to move the probe to the lungs? This can give you a status of the...
Please, Dr. Rayman, 3 minutes left.
Okay.
You have 3 minutes, Dr. Rayman.
Yeah, I'm going to finish within 60 seconds. Okay. So, why don't you use the probe and move it whenever your patient is suffering from dyspnea and you already found that there's a problem with the valve and a problem with the myocardium that could explain the heart failure. So why not to take a quick look whether this lung is dry or congested or in pulmonary edema. So whenever you put the probe over the lung, you are going to have this transverse line like this. This is a normal pattern for a dry lung. We call this A-lines pattern. They are a transverse line, as you can see here. Okay? But when those horizontal lines have been turned into multiple vertical lines like this, we call this B-lines. B-lines means that the lungs are wet. There is fluid inside the lung. So this could help you to guide you to diagnose at first that there is congestion and fluid in the lung parenchyma. And whenever you are going to apply medications and diuretics or these things, this could guide you to monitor the extent of the pulmonary congestion and the interstitial edema or the pulmonary. Also, apart from the lung examination, you can go and check for associated pleural effusions. So, to answer the title of my lecture, point of care ultrasound, is it worthy? Yes, focus nowadays is considered an essential complement to physical examination. We should start with a good proper history, taking good physical examinations, and being a good physician, you are going to put a theory for the possibilities and the different diagnosis about the patient problem. And whenever you are going to put a differential diagnosis and postulations for the problem of the patient suffering, you want to confirm things and rule out things. So you are going to shift quickly from your physical examination and trying to interpret what is inside your mind by confirming or excluding your impressions by doing this qualitative ultrasound examination. So focus helps you to make an immediate proper diagnosis at the patient's point of care. It's going to help you to make good decisions, and your good decisions will end up with successful interventions, and at the end, we are going to have a better patient's outcomes. And thank you very much.
Thank you so much, Professor Muhammad Abdul Mun'im, for this great talk. Our last speaker, but not the least, in this session is Professor Fatma Abul Ainain. She is a consultant non-invasive cardiologist at King Abdullah Medical City, Mecca. She is a professor of cardiology in Skandaria University, and she is a fellow and member of the American College of Cardiology and member of the Cardiac MRI and American Society. Prof. Fatma will talk to us about the multimodality imaging in prosthetic valve. And you know, sometimes these prosthetic valves are very difficult to figure out what is wrong. So you need to use your all tools to figure it out. Thank you.
Assalamu alaikum. Thank you for this kind invitation. Special thanks to Dr. Ala and the organizing committee for their generous invitation to this excellent workshop. So multimodality imaging and prosthetic valve. This is a complementary tool, especially in this distinguished echocardiographic course. Prosthetic valve dysfunction is an uncommon but a potentially life-threatening condition. The role of cardiac CT and cardiac imaging are in cases where echocardiography and cine fluoro are still inconclusive. And of course, I would like to explain to you that the cardiac MRI is still safe in prosthetic valves. So the mainstay of evaluation are really the transthoracic and the TE function is interpreted in the context of the valve type, the size, the position, the retrospective respective flow state. And of course, TE is invaluable because it's so important in these cases. But when echo is non-diagnostic, and another imaging modality is needed, especially looking forward to first for the cine fluoroscopy, the CT, and the cardiac MRI. Echo, although it is bedside, easily accessible for everybody, useful technique, but it still has its limitations, prosthetic valve, especially in valvular versus paravalvular insufficiencies, image thrombosis versus pannus, imaging of abscess and the extent of the abscess, imaging of aortic valve replacement because of the mechanical, in cases of double valve, in cases of mechanical mitral valve reverberation, and to assess the pulmonic valve by TE in the near field and shadowing and reverberation from other valves. So I have a couple of cases. Case number one, this is a 44-year-old admitted from the ER, status post-mitral valve replacement 10 years ago. She's just complaining of shortness of breath and coughing. Pulse rate is 100, blood pressure is 110/71, respiratory rate is 29. The echo transthoracic, done immediately in the ER, showed abnormal increased gradient of about 24 across the mitral valve. And so fluoroscopy was ordered. And as you can see here, there's the interventional cardiologist reported like this. There's a possibility for partial movement of one leaflet. We strongly recommend for urgent other modality to confirm a stuck valve. And so a cardiac CT was done. In the cardiac CT, we can appreciate here that this is the closed, this is systole, so it's closed. And here in the diastole, when it's opened, but you see they don't open nicely and correctly. The angle here is distorted. It's limited here. There's a low attenuation here. As you can see here, this black spot should not be there on the atrial side of the leaflet. And also with CT, we can actually trace it and measure the Hansfield unit of this area. And so in this case, the average Hansfield unit was around 100. And then there was another one here on the ventricular surface of the other leaflet, and you can see it here. And this one is a little bit higher in the Hansfield unit. And so the CT diagnosis, we diagnosed at a stuck valve, and combined rapid consultation with the interventional cardiologist and with the cardiac surgeon. And the consensus was to start with altiplase, and it was given. And then a transthoracic was done 2 days later, with the mean gradient significantly decreased from 24 and became 6 millimeter. So, well, of course, CT is important in the normal functioning of the prosthetic valve. We usually assess the opening angles like this should be like around 11 and then 8 بالعربي. Okay, and it should be like this. But if you feel that the angles are different, then an obstruction is diagnosed. The second case is an 18-year-old lady. She has a history of VSD repair, 2005, a history of metallic mitral valve replacement in 2008. She is on warfarin. She complained of shortness of breath and chest discomfort and fainting. The echocardiogram showed ejection fraction 55, prostatic mitral valve is well seated, but the peak gradient, the mean peak gradient is increased to be 18 with increase in the RV systolic pressure. Hopefully it will work, inshallah. And you can see here that this is not working. Oh, you cannot really assess it that well, but you can see that there's a lot of aliasing in the diastole. Again, the report was like this and need urgent fluoroscopy or CT to rule out aortic a stuck valve or something. Bismillah. So fluoroscopy was done. And it was reported to have partially stuck mitral valve with one of the leaflet moving and the other one not moving correctly. However, due to the poor visualization, try to confirm this with TE and cardiac CT. This is, I copied the report as reported by the interventional cardiologist. So in cardiac CT, what did we find? We found, like here again, the opening angle is distorted. They're not symmetrical. But you can appreciate here that there's something. There's something here like a calcification on the ventricular side of the prostatic valve here. And this is on the 3D rendering. You see like it has like two calcifications that are hindering the opening of the metallic valve. So the report said that there's a subvalvular pannus with an area of calcification resulting in restriction of the anteromedial mitral leaflet, and also the VSD was known, and so it was diagnosed to be a pannus. So one of the key parts of CT is to differentiate between a pannus and a thrombus. Of course, it's the time frame, pannus long time, thrombus is usually recent. The clinical status, acute and versus subacute or chronic. The valve, usually pannus is more on the mitral, while the thrombus is on the tricuspid mitral, and then the last is the aortic. And of course, the morphology, if it's small and dense, because it's mass made of fibrin, or is it mobile and large and density? And the most important part, and the most crucial role of cardiac CT is in the Hansfield unit. And so if the Hansfield unit is greater than 145, it goes more with the pannus, while if it's less than 90, or more than 90, I'm sorry, and less than 145, this is suggestive of a thrombus. So multi-slice CT is not the first, but it's the appropriate next step when you have an equivocal echo, especially like in these two cases, when there's even suspicion of an equivocal fluoroscopy. It evaluates the mobility, the extent of the limitation, how much is obstruction, how much is the Hansfield unit of this mass, if there's any leak or regurgitation, if there's any paravalvular leak, and of course, if we're going to redo surgery, it will give you information about the coronaries and the anatomy of the valve. Post-TAVI is an important part to be evaluated with cardiac CT, especially if there is subacute thrombosis of the valve, which is a real thing in post-TAVI cases. And of course, cardiac CT plays an integral role in this diagnosing of this disease. One of the other most important clinical scenarios where cardiac imaging is important in prostatic valve is in the endocarditis complication. So this is one of our patients. You can appreciate here that she had a 36-year-old male with fever and positive blood cultures. You can appreciate here is the aortic valve. It's well functioning, but there is a pseudoaneurysm, and I hope you can appreciate it here, which is opening because he had an aortic root abscess, and now it has a pseudoaneurysm opening into the LVOT area. Again, this is a similar case with the same outflow, pseudoaneurysm here. So it is projected that in cases of suspected infective endocarditis, you look as we clinicians do, using the Duke criteria, and then if it's definite, خلاص, then we diagnose it. But if it's possible, then you could consider further imaging by cardiac CT, and even consider PET or PET CT if you want to see if there's area of inflammation and infection. So cardiac MRI and prostatic valve, does it have a role, or is it really contraindicated because this is a prostatic structure? Cardiac MRI has the important diagnostic tool in accurately evaluating flow and accurately evaluating volumes. Of course, these are images from the Methodist Hospital, and you can appreciate here, this is a TAVI case, status post-TAVI, and here we can see here that on the flow there is paravalvular regurgitation. This is what we can see using the cine. But most important is that by calculating the volumes, you can accurately calculate the regurgitant flow volume so that if you need to redo the surgery or something else needs to be done. Again, also here, this is a prostatic mitral valve. It is still safe in cases of to go to CMR. And here you can evaluate the forward flow and the regurgitant flow, and accurately evaluating the regurgitant flow fraction by cardiac MRI. How do we do it? We do the flow here at the aorta, and then we calculate the flow across the mitral valve. So CMR is a useful complementary tool. It is safe in patients with prostatic valve, both mechanical, bioprostatic, and TAVI at any time after implantation, because the field that we're using is about 1.5, maximum 3 Tesla, but there's no risk of dehiscence or something bad happening to the valve. Of course, you always have to double check the same MRI safety by going to the MRIsafety.com website to ensure that this valve is MRI compatible. It's got limited value in cases of morphology, diagnosis of vegetation. Vegetations are small and mobile. You cannot evaluate them very well by cardiac MRI, but it's usual. Its most important role of cardiac MRI is in the quantification of prostatic valve regurgitation, volume, and fraction.
2 minutes left, yeah.
Yes, I'm almost done. And this, of course, this is the flow that we know how to evaluate the prostatic valve. Because an accurate evaluation of the regurgitant flow is important, and that is why here they say put CT and cardiac MRI is included in the algorithm. So in assessing prostatic valve function, of course, we have to evaluate using the echo, using the TE, but CT is important in evaluating of the valves, the opening and the closing, and if there's pannus or thrombus. Cardiac MRI gives you very good information regarding the flows and the volumes, and hence calculation of the regurgitant fraction. If you are suspecting infection, you can do PET CT or gallium to evaluate the infection of the patient. And this slide really depicts how useful each and every one of these techniques are. And as you can see, they are really good complementary tools to our basic echocardiogram, because this is the basic, easy, non-ionizing and bedside technique. And thank you for your time.
Thank you so much, Fatma. You can come here, please. We are lacking behind, but we can take like 2-3 questions to the Dr. Usama. And this Professor Muhammad is us here, Shabab. Prof. Muhammad is us online. Assalamu alaikum. Okay, so please, if you have any questions, quick question, because we are lacking behind really. دكتور ريم عندك أي سؤال؟
I'd like to thank all speakers for beautiful talks, and very specifically the last talk. My question goes to Professor Muhammad Ayman. The point of care, I don't think this is addressed for cardiologists, right? We are trying to let non-cardiologists get partial training in doing quick echo. Is this one of the messages? Yet they have to go back to a cardiologist because we're seeing lots of abuse of the point of care in pediatric cardiology done by non-cardiologists. It should be only for basics, but the detailed echo should go for a specialized person. Please correct me.
Good morning to Rahim. Yes, I totally agree. The issue of point of care ultrasound is to give a quick qualitative assessment at the point of care done by the attending physician, whatever his specialty. And then after stabilizing the patient, and the patient at that time, whenever it is stabilized and can be transferred, we can go for a detailed consultative echo. This detailed consultative echo should be done by a specialist in doing the ultrasound and the echo, and he is going to a full detailed report. So the initial one is the focus to help and make a rapid diagnosis, to identify the pathology, go through the proper management. And for example, a middle-aged adult coming with chest pain, and he's actually suffering from pericarditis. Sometimes we push him back into the chest bag, and they found that this patient is having a normal coronary angioma. Sometimes these patients with hypertrophic echocardiography, the characteristic deep T-wave inversion, the Japanese style, coming with chest pain.
خلاص كومنتس بس شوية كده منا.
So whenever we are going to pick up and make a quick diagnosis, putting the patient in the right way, then we are going to do a consultative echo by a dedicated specialist of ultrasound.
Thank you very much. Just a few comments. Actually, in our hospital now they are planning to give like 1 or 2 POCUS machines to the on-call doctor and to be indoors from shift to shift with the pager. So just a quick comment to Dr. Osama case. I don't think this is the left atrial appendage, right atrial appendage aneurysm because it is away. I think it is near the tricuspid valve, even distorting a little bit. It is a little bit away from. I think it is just the verticulum of the free area. I think so. And just last comment to Dr. Fatma. In our hospital also we stopped doing really this fluoroscopy for the stuck valve. We do either CT and T because within 30 seconds can give you the answer, full stop. In fluoroscopy you need to do like 360 rotation to take the valve from all angles. I think we should stop here because we should move to the next session. Because we are lagging behind. Thank you very much for all of you.
Just to honor Dr. Haytham. Remind the people who want to share the party to put his outside because we'll select from this the 3 teams. It will be 3 teams. Each team will compose of the 3 doctors. Okay? So don't forget to put your name outside.
كلهم consultants fellows everything. كلهم consultant fellows. كلهم يشاركوا. طيب أنا وين